Well, thank you. It's a great pleasure to be in this program, chaired by my friend Andres, who has introduced me to Colombia. And so it's great to come back. So we want to speak about, what is it? Prediction, prevention today, and preeclampsia, what we understand better about the pathophysiology now. And I show as a first picture the placenta, because I think we by now realize all that most of the problem starts in the placenta. I don't have to tell you what the impact of preeclampsia is. According to WHO data, it is still the third most frequent killer of women in the world. But in our country, for example, in Switzerland, 25% of all the very low birth weight babies are due to preeclampsia. So how did we get involved with the pathophysiology? It was by chance. When we were working on the non-invasive prenatal diagnosis, looking for fetal cells in the maternal circulation, many years ago, what we didn't realize was at that time that those pregnancies with preeclampsia, these are the open triangles, had many more fetal cells in the circulation than the control pregnancies. And we only got alerted to the fact that this material may be involved when this paper appeared in The Lancet, 1998, and there were some dermatologists from Paris showing that in this disease, polymorphic eruptions of pregnancy, in these lesions, they could find cells that were from a boy that this woman was carrying. So they realized that the traffic of these cells might cause problems in the pregnancy. What we did then is we looked at pregnancies with preeclampsia and those without in a blinded way. And here you see that those with preeclampsia, they had more fetal cells like we had suspected. And then Dr. Zong in our lab, she could show on the left side that when she looked at free DNA, there was an increased amount in these 27 pregnancies with preeclampsia, and the highest amount was in those with a very severe preeclampsias and the HELP syndromes. And on the right side, you see when she looked at the mother's DNA in her own blood, this also increased. And so the change on the right follows the change on the left. And therefore, we think that maybe this traffic of the material is the toxin in preeclampsia, in eclampsia. There is this hospital in Chicago where a plate is open for the person who delineates the cause of preeclampsia. You see Marshall Lindheimer here in front of this. And if you look at theories of preeclampsia already in the 50s, this is from a book of Ernest W. Page, he was saying that between the placenta as the origin and the maternal manifestations, there must be what he called chemical mediators. He was speculating what those might be, and he was thinking it might be syncytiotoxin, it might be autolytic products from the placenta, and I think he's right. So what we currently think is that the first hit in preeclampsia, of course, is the trophoblast invasion impairment. The spiral arteries don't open up properly. There's this oxidative stress. And this was delineated by the Belgian researchers, Brossens and others. What they couldn't explain is that only 50% of those pregnancies that have this trophoblast invasion disturbance develop preeclampsia. The others are just growth restriction. And what we see here is that only those who develop preeclampsia, the middle bar, they have the increased influx into the maternal circulation. And you will be maybe very surprised to hear the following data that come from the work of anatomists recently. Huppertz, now in Graz, previously in Aachen in Germany, he found that in the placenta there are about 3 to 9 billion mitoses every day from cyto to syncytiotrophoblast. It's because we need so many proteins, so much RNA. And this means that the syncytium grows 3.6 grams a day, but what we really measure is only 0.6 grams a day. And this means that the amazing amount of 3 grams of tissue go into the maternal circulation every day, fetal tissue that the mother has to handle. How can she do it? Well, these are particles that have a very controlled apoptosis that she can filter out in her own lungs, and only if the placenta has the hypoxic damage, then debris occurs, aponecrosis, and this shown here in this cartoon can be from intact cells all the way to free DNA, which we can then measure as a marker. So this is how it looks like. You see the intact, or more or less intact cells in the upper left corner, and the cell ghosts on the right down, where the free DNA then can be measured. And this debris, this material from the fetal side coming to the mother, can cause problems in the mother's periphery, in the endothelial cell system. So, for example, like in an infection where the mother, the neutrophil leukocytes, trap the bacteria, now these placental particles get trapped. Here you see this. We have shown that these are elastase positive deposits. This is staining for DNA. They are highly filled with DNA. This is why the cytox green shows so much color here. And they are deposited in the placenta. So in the left you see a control placenta, and this is how a placenta looks like then with preeclampsia. And I think this may be the reason for the Doppler changes we see in preeclampsia. We were even able to simulate this situation experimentally. We were creating little particles from the placenta, we were grinding placenta, and then we exposed them to the culture of umbilical vein endothelium, which grows normally pretty fast. You see that in the upper left corner. But if they are exposed to this debris, to this material from the placenta, then these cultures die very quickly. And this is, I think, the reason why the mother has her problems in the kidney and in the liver. I think we found another proof, and this was going to a very high altitude area. Maybe similar research could be done in this country, but we went to Tibet, very high, higher than the Swiss mountains, and what we saw was that those women who developed preeclampsia there in a hypoxic situation, they also had more fetal DNA, especially those Chinese who had moved there, who were not adapted. So we think there is good evidence now that this is really the messenger between the placenta and the periphery, but we have to be careful with theories about preeclampsia. Remember, there was a theory even one time that there were worms involved, and this was later found to be an artifact. But the worms, they never got along with the epidemiology of pregnancy. What do we know about preeclampsia? We know it's the disease of first paternity. And this is not surprising. The mother has never seen this haploidentical material from her partner. If there is damage already to her vascular system, then, like in diabetes, it will be easier to get the preeclampsia. If she has a lot of placenta, like in multiple pregnancies, it will be an increased risk. And the highest amount of fetal DNA we ever saw in a pregnancy was in this pregnancy. This is a partial mole due to triploidy. And these are pregnancies, interestingly enough, that have very early, very bad preeclampsias already in the second trimester. So this fits very nicely because you see the very large placenta, a lot of material going into the maternal circulation. So what we think happens is that this material goes to the maternal periphery. It also goes to her immune cells. And this explains why, for example, if the mother conceives after ovum donation, which is allowed in the United States, for example, she has an increased risk for preeclampsia because now the whole genetic material of the child is foreign to her. Or there was a paper in The Lancet where they obtained sperm surgically from the testes and used it for fertilization. Also an increased risk because the mother has never been exposed. So all of this then led to the question, can we use this to predict preeclampsia? Is this increase of the material there before there is the disease? And you know that currently, of course, Doppler is one of the best methods for predicting. You look for the notch, you see this increased impedance, but it's okay, but the sensitivity is not high enough. It's less than 50%. Specificity is higher, but it's okay, it's not perfect. So what we did is we used the Doppler to enrich for pregnancies that should become preeclamptic. We looked at 20 weeks, and now you see that looking at cells, those 15 pregnancies who later became preeclamptic had an increased amount of fetal cells. This was when we looked at the free DNA. We saw that it was 3 times higher already at 20 weeks than in the controls. And then Richard Levine came from the NIH, and he used the same technology on stored samples that he still had from a calcium study and could show the same. The gray bars are those pregnancies that developed preeclampsia, and starting at 20 weeks, they were showing higher levels than those who would not develop preeclampsia. And this is interesting because it's the same curve as we see for the FLT1 and the endoglin for the anti-angiogenic factors. So what we think is that preceding the disease, you see the increased fetal material and you see the change in the angiogenic and anti-angiogenic factors. And so now I think the race is on to develop a good algorithm that can be used in clinical practice for prediction. Many different candidates have been looked at. The early ones usually turn out not to be so good. But as I said, FLT1 and also the endoglin have shown to be the best. You know, it's probably not necessary to predict it already in the first trimester. But what you can see on this busy slide, which is from a recent publication by Kypros Nikolaidis' group, is that he can now show that you can predict 80% with a test positive rate of around 5 using the angiogenic markers. And what's currently ongoing is a WHO study where we determine the free DNA at the same time, and I can predict that this will improve the prediction of preeclampsia even further. And then I think this is what Kypros Nikolaidis' group found. They found a 91% for early preeclampsia, combining the maternal data, the biochemical data. But I think it probably will be the same like predicting Down syndrome, where just using maternal age with a 5% test positive rate, you detect maybe 30% of the cases. Combining nuchal translucency and age, it's better. But combining an ultrasound marker with 2 biochemical values and a historic value, the maternal age, then you have a 90% prediction. This is very robust, can be repeated. And I think with preeclampsia, we are almost there. So, final point, what type of preeclampsia do we want to predict? We want to predict the early onset preeclampsias, the very bad ones. We don't want to predict those that occur, let's say, at 36 weeks or so, because then they are easy to handle. And I can show you here in this slide that the highest amount of free DNA that we saw, you know, the 420 gene equivalents per milliliter, were in those pregnancies with the growth restriction and the early and the very bad preeclampsias. So this, I think, is good because it shows that the technique, that the test will be clinically useful. It detects those pregnancies that we want to detect. And I want to conclude by showing this slide from a quote from Chris Redman from Oxford that he gave in Reykjavik not so long ago. He said that preeclampsia may never be totally predictable, and I might add, may never be totally preventable. But I think if we have a better prediction, we will be able to filter out those pregnancies that need special attention, where the delivery has to take place in a center, and we can have much less invasive surveillance in the other pregnancies. And I think this is where we will see perinatology develop, that we will be able to better select the large group of very low-risk pregnancies, and then the small group of the high-risk pregnancies we can put all our attention on. Thank you very much.